Good evening, ladies and gentlemen, and thank you for joining us for another webcast brought to you by Optometry Australia this evening in partnership with Optometry New South Wales ACT. We'd like to welcome also our audience that have joined us today in the studio, and we're looking forward to a great evening ahead. It gives me great pleasure to welcome over 900 registrants to our webcast this evening. A webcast that is going to be run, and we're going to talk about glaucoma care and the future. We have some real eminent experts in the field, including Dr. Andrew White, ophthalmologist from Westmead Hospital in Sydney, as well as clinician and optometrist Mr. Jack Fu from the Centre for Eye Health. We're going to be concluding the evening with some really sort of important questions and some real topical issues around Medicare billing as well when it comes to glaucoma care. Before we begin, we're just going to go through a couple of housekeeping issues. Tonight's event, including successful completion of 70% of your multiple choice questions, will obtain credit with 4.5 CPD points that will be automatically added to your member portal in the coming weeks. If you choose not to do the complete or to conduct the MCQ questions for your CPD points, you will still be credited with 3 CPD points for watching tonight. In the coming days, I'll be providing you with the PDFs of the slides that you'll be seeing tonight, as well as a link to the recording, as well as a link to an evaluation form so we can hear from you and hear the feedback as to why this was such an interesting topic for you, why you've chosen to attend, and what you'd like to hear about in the future. There will also be a link to your MCQ questions following the evaluation in order to obtain the extra 1.5 CPD points as well. If you're having any technical difficulties or your AV drops out during the webcast, your platform should have a help button there where you're able to click on that and request somebody to help get you back online, hoping that doesn't happen tonight. We'd really encourage any sort of questions that you might have for our 2 main presenters tonight. Andrew and Jack will attempt to answer some of the questions that come through. Obviously, we may not be able to get through them all. There should be a Q&A button at the bottom of your screen. If you click on that, you'll then be able to click on the word ask and type in your question. We'll try and get through as many of the questions as we can tonight if possible. Before we get Jack Fu from the Centre for Eye Health up to start our evening, we're happy to invite Mr. Andrew McKinnon, CEO of Optometry New South Wales ACT, to just say a few words and to welcome you for the evening. Andrew.
Simon, thank you. It's been a long time since I've been called Mr. Makes me feel like my father. Welcome to New South Wales. I hope you have a wonderful evening. As Simon has said, it's a terrific panel of Jack and Andrew giving you some really cutting edge information on glaucoma. I'm here simply to say I hope you have a great evening. My little sales pitch to you is that as membership comes up in the next few months, when you're thinking about joining the association, I hope you'll think about us as the team that cares for you. That's what we're here to do. We're here to look after your interests as optometrists. No one else does it. No one else has the expertise. You've got the experience of people like Simon and Luke Arundel from our national office and others around all the states there with only one job in mind, and that's to look after you. So look, with our thanks to the Australian Dental Association, the New South Wales branch, for giving us their sensational facilities, we really appreciate it, and we hope you appreciate the quality of the broadcast that comes to you tonight. I'll hand you back to Simon and we will be away for the evening. Have a good night.
Thanks, Andrew. Really appreciate you taking the time tonight to say a few words and to welcome our audience here in the studio as well as online. Now, ladies and gentlemen, let's kick off the evening. Tonight we have Jack Fu from the Centre for Eye Health, as I mentioned. Jack is currently the glaucoma lead clinician and is completing a PhD at the Centre for Eye Health in New South Wales. He obtained his undergraduate optometry degree in 2011 from the University of New South Wales, and he completed a Masters in Public Health and became a Fellow of the American Academy of Optometry in 2014. He's involved in teaching ocular disease, ocular therapeutics, clinical optometry and visual neurosciences. He's a very busy man. At the undergraduate and postgraduate level at the University of New South Wales, he's published numerous papers and presented at conferences in the area of glaucoma and visual psychophysics. And he's been awarded numerous travel grants and the Optometric Glaucoma Society Easel Fellowship in 2016. Jack Fu, thank you for joining us this evening.
Thanks for the introduction, Simon and Andrew. It's great to be here. Thanks to everyone for taking the time out of your busy schedules to attend tonight's webcast. It gives me great pleasure to talk to you today about OCT reading and glaucoma diagnosis. And my hope is that after tonight's webinar, you'll go away with some practical tips that you can implement directly into your practices when you go back to work tomorrow. So just some housekeeping. I have no financial disclosures or conflicts of interest to report in this talk, and some of the research work that I'm presenting that's been done in our lab was supported by an NHMRC grant. So these are learning objectives for tonight's talk: to compare the use of cross-sectional and longitudinal data for developing a diagnosis and management plan for glaucoma, to recognize cases of red and green disease. These are terms that you're going to see floating around a lot in the literature and in our professional magazines as well. And to thirdly, identify signs within the OCT results that might suggest a non-glaucomatous optic neuropathy. So not everything will be glaucoma, and it's very important that you recognize these cases when they come. So we know that the definition of glaucoma is a very complex one, and one that has evolved over the years. And this is a very nice comparison of two definitions that were written in a paper by Bob Cass and published in Clinical Experimental Ophthalmology. So on the left of the screen, you should see a very simple definition of glaucoma, and this is a very traditional way of thinking about it. But on the right-hand side, what we see is a far more multi-layered and complex definition, which encompasses a lot more of the knowledge that we've developed over time in terms of understanding the pathogenesis, etiology, and the clinical presentation of glaucoma. Indeed, one of the biggest points about this particular multi-layered definition is this idea that perhaps visual fields may not be defective at the very early stages of glaucoma, and that really occurred as a result of these advanced imaging modalities and increased understanding of what glaucoma is as a disease. One of the points that I've highlighted in the slide here is that glaucoma is potentially progressive, and really one of the questions from this particular talk is asking you, does the diagnosis of glaucoma require documented progression? That's something to bear in mind. As mentioned already, the diagnosis of glaucoma has no gold standard, but a set of clinical standards do exist for defining glaucoma. So in terms of the structural examination, we have stereoscopic optic nerve head examination as the clinical standard for this, but obviously there are problems associated with that in terms of the repeatability and between observers and between visits. The functional tests, as we all know, the clinical standard is white-on-white standard automated perimetry, static perimetry. But again, as I mentioned in the previous slide, there are problems associated with that in terms of the early detection of functional loss. Plus or minus some historical factors, then what you have here is called a Bayesian approach, where you add up all these risk factors and clinical signs to ultimately arrive at a diagnosis of yes glaucoma or no glaucoma. Really, the crux of today's talk is asking this particular overarching question, which is, can OCT, which is an objective, repeatable, and quick technique, solve the problems associated with fundoscopic examination, which is our current clinical standard for diagnosis of glaucoma? I would note that the Cirrus OCT is the one that we're preferred at the Centre for Eye Health, partly because it's the one that we have the most experience with. And so the printouts that I'll be showing today are primarily from the Cirrus OCT. But a lot of this advice can be very generalizable to your other instruments from other manufacturers. There are a lot of questions that you can consider when you do look at an OCT printout. And these include, is the result reliable? So we need to check things like the signal score and artifacts. We need to know and understand the difference between what a heat map or a thickness map is with a deviation map, which is a statistical analysis performed on the result. We need to check for symmetry or asymmetry between the eyes, looking at the Tisnet curve, or if you have a TopCon with the hood printout, the NSTIN curve instead. And so with that in mind, we're going to start with case one, which is a 53-year-old Hispanic male that I saw a couple of years back. As we can see here, I've identified a couple of red flags, the really high IOPs, more so in the left eye compared to the right. What we can see in this gonioscopy photo and the anterior eye shot are lots of pigment. Lots of pigment in the angle, lots of pigment in the anterior segment. There were some iris transillumination defects, so it's clearly pigment dispersion syndrome. What we have now is the fundoscopic examination. So now that we've established the anterior segment signs, we want to look at the posterior segment to see if the pigment dispersion syndrome is affecting the optic nerve. What we can see here is an enlarged cup disc ratio, or an enlarged cup in the left eye particularly, and also some decreased RNFL reflectivity just on the basis of fundoscopic signs inferiorly in both eyes. Then we do the visual field test. What we can see here is question mark, no visual field defect, or no cluster of significant points that would constitute a statistically significant visual field defect. The question is, can OCT help in this particular case? And the answer obviously is yes. What we have here is a very typical RNFL optic nerve head Cirrus OCT printout, and I'm just going to step by step go through these to make sure that we're all on the same page with regard to analysing these results. So starting at the very top, what we have is the RNFL thickness map and the optic nerve head and average parameters overall. This is a heat map. So basically, the hotter the colour, redder, yellow, orangey colours, it means that more tissue is present of that particular layer of interest. In this case, the RNFL. So we have here some depressions, as you can see, as indicated by the yellow arrows, in typical glaucomatous areas, so the superior and inferotemporal regions. We have some asymmetry, very slightly in terms of the overall RNFL thicknesses and the optic nerve head parameters. We don't really look at that, to be honest. We mainly just look at the RNFL parameters in this particular printout. Then we step down and we look at the deviation map. So the deviation map is a statistical analysis applied to the thickness map above. So basically those superpixels, those little squares, yellow or red, represent some statistical probability of that particular result lying within the normative distribution of that instrument database. So if it's a red one, then it's highly statistically probable that it's a defect of some kind. What we have here highlighted superiorly in both eyes is that there's some statistically significant dropout in the shape of a wedge-like pattern of defect. And again, that's a very classic sign of glaucoma, as we typically note that in our fundoscopic signs. Then, stepping down further, we have the RNFL thickness map, or the Tisnet plot. So this one takes some sections across the scan circle and highlights the thickness at those particular locations around the optic nerve head. And what we can see here, the solid black line being the right eye and the dashed black line being the left eye, we see some asymmetry on the Tisnet curve. And that corresponds to what we see on the thickness map, the heat map, and the deviation map. Stepping down further, we look at some of the fine thickness values specifically to the clock hours. And again, we have some corresponding RNFL asymmetry. So in combination, what we have is a very clear structural evidence of glaucomatous damage in the context of pigment dispersion syndrome. So we have a diagnosis of pigmentary glaucoma left greater than right. In this particular case, we initiated treatment straight away for this particular patient and sent him up the road to the Prince of Wales Hospital. In contrast, we have this particular case, which is a 45-year-old Asian male that I saw a couple of years back as well, with untreated hypertension as the interesting part of his medical history. What we can see here is some very suspicious looking discs, some enlarged cup in both eyes, left maybe a little bit more than the right, and some RNFL dropout as highlighted by the black arrows there. We can see that quite prominently in this younger looking eye. There's no nipping or nicking, depending on your nomenclature, but there is some clear broadening of the arteriolar light reflex, particularly superiorly, as I've highlighted here in the yellow arrows. Taking a look at the visual field result, there's no corresponding visual field loss in the right eye, but there's perhaps some corresponding visual field loss in the left eye. So what we have is some superior dropout of structure in the nerve fiber layer, and we have some corresponding inferior visual field loss there. Doing the OCT now, again, just stepping through the RNFL thickness map first. What we can see highlighted by the red arrows for the left eye as some areas where there is RNFL dropout, and that is statistically significant. In the right eye, though, I have a red question mark there, and it's because it doesn't necessarily correspond to where we've identified the region of structural loss in our fundoscopic examination. So it seems to correspond on OCT to the left eye, but maybe not to the right eye. There's clear asymmetry again when we look at the asymmetry analysis and also the RNFL thickness Tisnet plot. So is this glaucoma? I mean, we have some fairly convincing signs there. We have some structural loss, some functional loss, and some asymmetry. So when we count all those factors that are in support of a diagnosis of glaucoma, we have RNFL defects, we have matching retinotopic visual field loss, we have bilateral but perhaps asymmetric structural loss and functional loss. But factors against glaucoma is that this patient is relatively young. The neuroretinal rim is not clearly affected as well, so even though we have some RNFL loss, it's not stretching all the way down to the neuroretinal rim as we would typically expect in a case of glaucoma. And what we also have is bilateral early hypertensive changes, as we can see here in a magnified view. So really, I think in this particular case, just given this particular cross-sectional data, this one-time visit, It's most likely a case of ischemic RNFL loss and maybe a bit of glaucoma suspect on the side because of his suspicious looking disc and RNFL. So in this particular case, the management plan, instead of initiating treatment, was to monitor for progression. And really, this is where we highlight the value of longitudinal data, because we ask the question, is there justification for treating this patient without clear evidence of progression over time? Because if we go back to the definition of glaucoma, in which it is potentially progressive, a lot of the time we maybe only treat glaucoma on the basis that it's going to affect the patient's quality of life or visual field or visual function later on. But in this particular case, if there's no evidence of progression or likelihood of progression, then maybe we can withhold treatment for the time being after some informed consent. So perhaps maybe we can rephrase this idea of potentially progressive to something that's like detectable progression. Because remember, we're again trying to rely on some fairly imperfect clinical techniques to try to identify progressive loss in these particular patients, both from a structural point of view and from a functional point of view. So, value of longitudinal data. We've seen this patient 3 times now, and we've had some front-loaded OCTs at baseline, and we've had some subsequent visits in a few months' time and a few months after that. And what we can see here as, again, just stepping through this particular progression printout, starting at the very top, looking at the thickness and heat maps, there's no qualitative change. So we can this is actually quite powerful because we can start to maybe identify regions where the RNFL is not quite as thick, or when you start to have a development of a wedge defect or a widening of an existing wedge defect, but we see no such thing here. There's also no statistically significant change apparent on the deviation map, which is the statistical analysis, and there's no quantitative change in the RNFL or optic nerve head parameters. So we're stepping through all of these different optic nerve head and RNFL values. There's no significant change. And so we are in agreement with our original diagnosis at baseline, which was a more likely ischemic RNFL loss and glaucoma suspect that has remained stable over this period of time. And again, the management will be to monitor for progression. So the first clinical tip that I hope you take away is that in comparison to having just purely cross-sectional data, longitudinal data can really help to support or refute a diagnosis of glaucoma over time. So one of the main advantages of OCT is that it presents to you quantitative data. So you have a series of numbers here, and that's great because you can tell patients like, oh, you're progressing or you're not progressing on the basis of these numbers following up over time. But really, the fundamental assumption here is that these numbers are correctly identified. So really, moving on to case 3, this is a 67-year-old Caucasian female that I've seen a few times as well. She's one of our most avid supportive research participants as well, so very grateful for her help. And when we look at her fundus photos, what we can see here is a very atypical disc appearance in both eyes, with some possible thinning of the neuroretinal rim. But again, it's very hard to judge because it's a very atypical disc appearance. So I'm going to put some question marks everywhere because it's nearly impossible to visualize the RNFL reflectivity near to the disc, in contrast to that previous case that we saw. So this is where we do our next suite of tests. So we do some functional tests and some structural OCT. So we ask ourselves the question, is there a matching visual field defect? So perhaps, but it's hard to say because we can't really pinpoint exactly where the structural loss is on the basis of fundoscopic examination. So moving over to the OCT result now, and again stepping through, we have clearly identified some areas of red superpixels in the deviation map. So those ones are, remember, highlighting those areas where there's statistically significant reductions in RNFL thickness in that particular area relative to the normative database. And stepping through down into the lower part of the printout where we're looking at the quadrants and the RNFL clock hours, and they seem to correspond and have some highlighting some very statistically significant depressions in RNFL thickness as well. So there are red flags everywhere, but does it necessarily mean it is glaucoma? The distribution of RNFL and optic nerve head parameters obviously looks atypical, and that's confounded by the appearance of the disc. The wedge-like defects also that we can see on the statistical analysis on the deviation map also follow a wedge-like pattern and follow the contour of the blood vessels. There's some general symmetry between the RNFL and the Tisnett plot if we follow the solid black line in the Tisnett and the dashed black line in the Tisnett as well. And again, that's maybe not one of the hallmarks classic for glaucoma. So this is at the very bottom of the printout, and this is a B-scan that goes through the eye to identify the regions of the RNFL thickness that then produce these subsequent thickness maps. So these ones are often overlooked, and when you get the printout, they're often quite small, localized to the corner. And so one of the advantages of producing this on your instrument and looking through it very carefully is that you can then blow it up. And what this helps you to do is to identify if the instrument has correctly marked out where the thickness of that particular retinal layer is. And this kind of clinical tip is applicable to all sorts of diseases, including macular disease, diabetes, and so on and so forth. And the purpose of this particular printout and blowing it up like this is so that we can try to identify whether the instrument has correctly identified the retinal nerve fiber layer in order to give us an accurate reading for this particular patient. And what we can see here, as highlighted by the yellow arrows, there are areas where the delineation of the retinal nerve fiber layer is completely inaccurate. So it's actually flagging it to be a lot thinner than it actually is. So in reality, it should be a little bit thicker than that. So these are errors in RNFL segmentation, which then are attributable to the atypical disc orientation, which then leads to all these red flags appearing throughout our printout. So the question then is, can we use an alternative scan protocol, such as the macular one? Because when the macular GCC and the GCA, the ganglion cell analysis, ganglion cell complex, ganglion cell printouts were first released, there was a lot of buzz about whether or not this can really help us in the case of an atypical disc presentation like this, because it's perhaps not affected quite as much as the RNFL optic nerve head printout. So the answer in this particular case is no. There's actually similar segmentation, errors in segmentation in this particular case, attributable to the tilt of the retina in that particular area. And as we can see later on, it's related to the ultimate diagnosis and final diagnosis for this particular patient. And again, what we have here is the value of longitudinal data. So we've seen this patient many times already. And although maybe the instrument hasn't correctly identified the layer correctly the first time at baseline, such as the RNFL in this particular printout, what we can still do is try to monitor that over time to see if it's progressively thinning. Because again, one of the hallmarks of glaucoma is that it has some kind of detectable progression over time. Again, the longitudinal data is incredibly valuable using the same instrument. Ultimately, the diagnosis for this particular patient, the combination of fundoscopic signs, the visual field defects that we've seen that predominantly located within the temporal region, all combine to produce a diagnosis of benign tilted disc syndrome. In our particular case, just looking at the OCT, this is a case of red disease because we have red flags everywhere, but it's not necessarily disease. So the value of additional testing, I can't help myself but to plug a little bit of psychophysics research. To know that it is tilted disc syndrome, we ask ourselves the question is, can we overcome the optical error associated with posterior bowing? So that tilt that we got in the GCA printout, can that be overcome by using optical correction? And the answer is yes. We can use in this particular case, a -2 negative addition lens. And what we can see here is that the defect is basically completely eliminated. And that's because with a negative lens, we can refocus rays of light more accurately onto the retina. So case 4 is a 74-year-old Asian male, average CCTs, average risk factor for glaucoma, but very suspicious looking discs. And I think everyone can see some very suspicious features in the fundus photo as well. We can see loss of neuroretinal rim in the superior region in both eyes and loss of RNFL reflectivity in that superior region as well, quite adjacent to the retinal vascular arcades. And we can see a Drans hemorrhage highlighted by the yellow arrow. Then we do the visual fields, and what we can see here is a superior loss structurally corresponding to an inferior loss functionally in both eyes, maybe a bit more so in the left eye compared to the right eye. So we have maybe structure function concordance going on when it's just looking at the fundoscopic signs and the visual field signs. But then when we look at the OCT, everything is green. So one of the tempting things to say to our patients sometimes, green means good, but not necessarily all the time. Because green in reality is still related to the normative database and the distribution underlying normative distribution. So if the patient started off supernormal but has progressively lost RNFL over time, that still constitutes glaucoma, even though it might not be flagged by the instrument itself because it's still within the instrument's normative database. So what we can see here highlighted is, again, all green, no asymmetry. Again, both of those things maybe not indicative of glaucoma, but highlighting that particular tomogram again, that's typically wedged at the bottom of the printout, blowing that up to try to check for areas of segmentation or any other artifacts that might be causing this abnormally thick RNFL result on the rest of the printout. What we can see here is that the RNFL layer looks really, or the retinal nerve fiber layer looks really thick around the area of the blood vessel. And I've highlighted here with the vertical yellow arrows the areas of thickening apparent on the tomogram, which is the printout on the left, and corresponding to the area highlighted in the fundoscopic photo on the right. So what we have here is a case of glaucoma. Still, because the fundoscopic signs match the functional visual field signs, but not necessarily with the OCT, this is a case of green disease. So one of the take-home messages I really hope that you can take away into your practices is that don't rely upon the traffic signals, the red, green, yellow, red, yellow, green, seen on the OCT, or any other test that uses normative data, even in visual fields. And remember that artifacts such as the errors in segmentation can lead to inaccurate comparisons with underlying the normative database. And so really that's the clinical tip number 2. So look beyond the red and the green and carefully analyze the overall test results. Final case for tonight, a 53-year-old Asian male was referred for suspicious cupping, and I think everyone here would agree that it looks highly suspicious, particularly superiorly, inferiorly. But what we try to do now is to localize specifically structural loss to see if it's glaucomatous in origin. We do the visual fields, 30-2 in this particular case, and what we can see here is we ask again the question of, is there corresponding functional loss? So if there's both superior, inferior structural loss, you might expect to see superior, inferior functional loss as well. We kind of get that in both eyes, but what we've highlighted here in the boxes is this apparently clear split along the vertical midline. If we look firstly at the very top printout, those are the raw threshold values, so sensitivity values. And what those tell us is, gives us a numerical representation of the depth of visual field defect. Because if you compare it to the one on the bottom, what we have is just a series of black and gray squares, which tells us the statistical significance of the defect, but it doesn't necessarily give us any information about the depth of the defect. Only that it is highly statistically significant or just low statistical significant. So it's very important to look at both of those printouts to get the complete clinical picture with regard to the functional results. So we'll come back to that, but what I've highlighted here is at the very bottom, on the right we have the fundus image, and below that we have the corresponding visual field image. So I've put them as per our visual field convention. And on the left here, now I have the OCT printout. And the question again is that, I guess at the end of the day with this particular talk, does the OCT correlate with the fundus appearance, or does it correlate with the visual field appearance at all? We have these weird areas of depressions of the RNFL. It's not really in that clear superior or inferior region, but mainly in that temporal region. So the question is, what kind of defects are these? Looking at the GCA printout, because I guess if you trace the path of the retinal nerve fiber layer temporally, then you're going to go and hit the papillomacular bundle. So I guess it's logical then to look at the macular scan. And what we can see here in both eyes is a vertical cut. So again, we apply the same principles that we went through in the previous cases already. We have the thickness map or the heat map at the very top, and then on the sides we have the superpixels that represent statistical analysis of these depressions. And these are very, very suspicious, and they seem to mirror the visual field defects that we're seeing on the pattern deviation maps there. So what we actually have here is not a diagnosis of glaucoma, but rather a left incomplete hemianopia. So we need to refer this particular patient immediately for neuroimaging because he likely has a right retrochiasmal optic tract lesion. So one of those cases as well where it's very easy to mistake it for glaucoma because it has some very suspicious signs of cupping, visual field loss, red flags, asymmetry, a little bit of asymmetry on the RNFL printout, but very important to check very carefully for signs of these suspicious vertical cuts. Also, these vertical cuts are applicable in quadrant cuts as well. So typically with glaucoma, we expect something that respects maybe the horizontal midline at the beginning. But if you have a quadrant of loss, then we really need to be suspicious for something that's a little bit, that's beyond the retina. So really the clinical tips to analyzing a result like this is that we check the heat map and thickness map. Is there a presence of a vertical cut, or does it really follow a trajectory typical of glaucoma or other retinal optic neuropathy? So like an arcuate-like defect, or a wedge-like defect, we check for those. We check the sensitivity differences. As I mentioned already, the numerical values at the top of the field printout give you the depth of the defect as well, and we compare them across the vertical midline. And as a general rule of thumb, about a 10 dB difference is quite suspicious because that's over 3 log units. That's a log unit of difference, and that's quite significant in this particular case. Does it correlate with the disc appearance? So aside from the fact that there's apparently cupping going on here, the neuroretinal rim otherwise looks reasonably intact. Maybe a little pallor on the temporal rim, but the neuroretinal rim doesn't show that characteristic thinning or notching and focal loss that we expect in glaucoma, particularly showing a superior-inferior asymmetric distribution. Using this knowledge, we can then apply it to theories on retrograde degeneration, and we can try to localize where the lesion is going to be. So this is some work that's been published by our lab recently, which is a very useful clinical guide for trying to localize where the lesion is likely to be based on the visual field results, based on the RNFL printout, and based on the GCA printout. This is in clinical experimental optometry. It's open access, so everyone is free to access this. And there's a very similar one on the CVH chairside reference website. So the third clinical tip is really beware structural and functional deficits that respect the vertical midline, and be really suspicious for etiologies aside from glaucoma. So really, in conclusion, I really hope that I've imparted these clinical tips upon you, and hopefully they'll be very immediately applicable in your clinical practices. So firstly, longitudinal data is very additive to the diagnostic process, and it's again one of those things where you can build a really good relationship with your patient over time as you're testing them on the same instrument and seeing them for regular checkups. And this can really help you to titrate treatment and follow-up protocol for this particular patient. Be aware red and green disease don't get sucked in by the traffic light signals, and we have to really carefully inspect the quality and the reliability of the scans to see if there's any other cause for these red and green signs that appear in the printout. And finally, be aware of vertical and quadratic cuts in both function and structure, as these may indicate more sinister diagnoses aside from retinal disease. Thank you for your attention.
Thanks, Jack. That was a lot to get through.
Yeah.
So you can join us at the podium so that everyone can see you at home. Don't rely on the traffic signals. I like that. I think that's really important and something that sort of moving forward, I think that more and more clinicians probably need to be aware of in terms of sort of getting sucked into that red and green disease. So we do appreciate there was a lot to get through. Thank you for that. At home, we do appreciate that some of the slides are a little bit difficult to sort of see, particularly based on the resolution. Unless you're watching it on a 60-inch screen at home, it will be a little bit difficult. We are going to provide all the slides in PDF format. You'll be able to blow them up. We'll be able to sort of give them to you in fairly good resolution. So rest assured that whilst we weren't able to blow up some of the OCT results that are obviously being scanned in, we'll make sure that you get all that information to you shortly. Jack, we've got a few minutes for some questions. We had quite a few come in online, and there might be a couple in the audience, but we just want to run through a couple if we can, just before we get Andrew White to talk to us. Sure. So one of the questions was, you mentioned the sort of the machine's normative database, and someone was asking sort of how many patients sort of make up the normative database for the Cirrus. So what are we looking at in terms of numbers?
Oh, a tricky question off the top the bat. Off the top of my head, it's about 254 from memory.
Yeah,
that's right.
Okay,
oh, good. Paul is here to fact check me, so it's all good. I think one of the other important things to remember about the normative database is not just how many patients, but the distribution of the patients as well. So the age, gender, ethnicity, refractive error, they're all very important considerations to see if your particular patient rests within that normative database. Especially at the high end and the low ends, if you're only comparing with like a small subset of that normative database, then your conclusions are going to be very skewed in one direction as well.
Thanks, Jack. Someone else asked, in monitoring longitudinal data, is sort of 6 months appropriate? Is that sort of the...
Yeah, that's again, one of those questions where in the last point that I tried to make is titrating the treatment depending on your individual patient's circumstances. So I guess to have good baseline data, we might want to see the patient a bit more frequently at the beginning. But over time, if you see that they're quite stable, you can stretch it out. Like then it's one of those you see front load to get some good reliable data to try to estimate a trajectory for that particular patient and try to catch them before they progress too fast. Yeah. So yeah, I think 6 months is quite fair at the beginning, but if they have more risk factors, then obviously a little bit shorter than that, like 3 or 4 months. Instead.
Okay, so that leads into the question someone was asking, what's sort of the minimum time between OCTs to detect progression?
Yeah, that's a tricky question as well. It really depends on the instrument that you're using and the rate of progression for this for patients. I think one of the patients that we had at the centre as well didn't actually progress that quickly overall, partly because for statistical significant progression, you need to overcome the inherent test-retest variability of the instrument. So while quantitative data is quite good, for it to be flagged as something that's significantly progressing, we need to overcome that range of values that that particular instrument I guess, can potentially measure at that particular visit. So for example, if your test-retest variability was 5 or 6 microns, then you need to overcome that 5 or 6 microns in order to detect a significant change overall.
Sure. Just one more before we get you out of the hot seat. Somebody was saying that in one of the case studies that the scan was misaligned, and sort of how to go about detecting that misalignment. They might have missed that explanation if possible.
Yeah, that's a great question as well. And the short answer to that particular case in case 3 is that it's very difficult to align it quite accurately with a patient with atypical disc or atypical fundus, because when you try to align the optic nerve scan circle on the optic nerve itself, you might actually get too much of a retinal tilt, and you might cut off part of the scan or truncate part of the scan. Then if you try to align the entirety of the scan, you might be in a different part of the fundus as well. So what I guess the tip I would give to those particular patients is to try to get the scan circle to align at the same place consistently across your visits, maybe make appropriate clinical notes. A lot of contemporary instruments have tracking software, so you can actually track the location of the blood vessels and the instrument will automatically realign the scan for you. But there are some cases where the fundus looks really atypical, abnormal, and the internal tracking software has some difficulty realigning the scan for you as well. There's also some instruments that can do some post-processing as well. So even though you may not have done a particularly good job at lining it up the first time, and at the post-processing stage, they may be able to realign and track that particular region of interest in your patient as well.
Jack, a wealth of knowledge. Thank you for joining us tonight. We really appreciate it. Ladies and gentlemen, stay tuned with us. We'll be back with Dr. Andrew White discussing glaucoma and neuroprotection in just a minute. Thank you. Thank you for joining us again, ladies and gentlemen. I'd like to now invite Dr. Andrew White from Westmead Hospital, ophthalmologist, who is going to discuss glaucoma and neuroprotection, the final frontier. Dr. White is a clinician scientist ophthalmologist at Westmead Hospital in Sydney. His subspecialty is glaucoma, and he was awarded a first-class honours in medical science in 1995. He completed a PhD in 2001 from the University of Sydney. He also undertook research work at the Max Planck Institute for Biophysical Chemistry. This research focused on the characterisation of the corneocellular visual pathway, responsible for blue-yellow colour vision, as well as the physiology behind colour vision and glaucoma testing in detection of glaucoma using FDT. He was trained at the Sydney Eye Hospital and undertook subspecialty training in glaucoma at Westmead Hospital in Sydney, as well as at Adam Brooks Hospital in Cambridge in the UK. 2011, Andrew was promoted to the post of consultant ophthalmologist and senior lecturer in ophthalmology at Cambridge University in the UK. Andrew undertook research at the Centre for Brain Repair and has recently been looking at neuroprotective agents to prevent the progression of glaucoma. Thank you for joining us, Dr. Andrew White.
Thanks very much, Simon. And now for something really completely different. We're going to talk about neuroprotection in glaucoma. So we'll talk about what that means. First of all, just the standard disclosures. I'm involved with development in many companies, but none of this is particularly relevant to what I'm talking about. Okay, so neuroprotection in glaucoma, why should you care? Well, we know by 2020, about 70 million people will have glaucoma. Well, they have glaucoma now, but by 2020 it'll be about 110 million. In Australia, currently, there's about 400,000 people with glaucoma. And we know that in a lifetime study, approximately a quarter of people with glaucoma will go blind in at least one eye. Now, we can reduce intraocular pressure, which is a mainstay of treatment, in many ways. In the last 2 or 3 years in particular, the surgical options have exploded, and we're getting a better understanding about how unreliable people are at taking their drops. So we can reduce intraocular pressure, but that's not nearly enough. And it's mostly because you have to think about what glaucoma is. Essentially, it's a disease of ganglion cell apoptosis. The ganglion cells and the nerves going through the optic nerve, they're dying at a faster rate than they might otherwise. The average person might lose 7 or 8 ganglion cells a day through natural aging. If you have glaucoma, maybe it's 70, maybe it's 700. It's just all happening a lot faster. So neuroprotection is about slowing and arresting these apoptotic pathways Unfortunately, people have tried for years to get this to work as a treatment, and it's cost billions. Infamously, there was a drug called memantine, which was originally an Alzheimer's drug that was used as a neuroprotective agent, or at least was trialled. Those results have never been released. It's assumed it was a negative finding, and it cost at least $2 billion to the developing company. It may well be there was some problems with the testing and understanding what was going on. And so we'll just discuss that a little bit further as we move on. Okay, so getting back to, aren't current treatments good enough? I mean, with all the explosion of new surgical devices in particular, isn't that great? Aren't we going to cure glaucoma? No. Basically, most studies suggest that there's at least a 15% lifetime risk of bilateral blindness in glaucoma, with a further 26% of people blind in one eye. Now, these are studies from Scandinavia, which has one of the best designed health systems in the world. That's not counting places like even America or the UK, where the figures are worse, as you can see at the bottom of the screen. So therefore, it's quite clear that our treatments are nowhere near good enough. So where are we up to? Now, glaucoma is still one of the leading causes of irreversible blindness in the world. People have tried and failed to regenerate nerve cells in the retina. We just aren't there. The quoted study here from experimental eye research in 2010 cited at least 50 potential neuroprotective agents that work great in a test tube, or mice, or rats, or experimental models, but none of them have ever translated into a clinical trial. And it may well be that there are flaws in the current trial design. Now, there's a lot of confounders with neuroprotective agents, because we'd also probably want to concurrently lower intraocular pressure. And we're also looking for small changes on OCT or visual field over a relatively long period of time, and that can be quite hard to pick up in inherently noisy data. So people are working towards new forms of progression analysis. There's one called ANSWERS, which was designed by a group in the UK. And that is being applied to studies such as this one, the UK GTS trial. Now, I don't know if people are familiar with the UK GTS trial. On the surface, it's not very interesting. It's latanoprost versus placebo, and it shows that latanoprost slows glaucoma progression. Big deal. We've known that since 1991. But what is important about this study design is that they could show a neuroprotective effect of lowering intraocular pressure in a very short period of time by changing the way visual fields were done. They did a lot at the start of the trial and a lot at the end of the trial, and very few in the middle. And they could pick up small changes that in previous studies like EMGT, which was also about latanoprost really, that took many, many more years to figure out. So it may well be that some of the molecules that were tested before actually do something useful. We just weren't picking up these small effects well enough. But there's probably more things on the way. It could well be that not every drug works for every patient. As I said before, it's very complicated, the apoptotic process for glaucoma. It's essentially a game of molecular dominoes. One gene gets dysregulated, dysregulates a protein, leads to another one, leads to another one, leads to another one, leads to another one. Eventually you get cell death. There are many, many genes involved. At the last count in some of the consortium studies that I'm involved in, somewhere between 100 and 140 particular genes are involved. Now, it's not the same genes for every person, but there are a variety of studies, such as the one cited in this slide here, that shows that certain genetic susceptibilities can lead to glaucoma. In this case, from GWAS studies, TMC01 and CDKN2B, which is one of my favourite genes. And we'll talk about this a little bit later. But there's been heaps of other ones, ABCA1, AFAP1, GMDS. I won't bother reading it out, nor the author list, although if you look hard enough, I'm author number 17 in that one. If anyone ever wants to know, the limit that you can have on authorship is 200. It was set by Nature years ago. So we're under that. But anyway, more genes here, more genes again, and there is another one that's going to come out soon that talks about 101 genes in one hit that I'm involved in. So that gives you some idea of how complicated all of this is. Okay, all right. But that's just genome-wide association studies. It's, for people that are not familiar with genetic analysis, essentially that is just looking at large groups of patients and blood collected from them, and it just looks for regions where their genetic map is slightly different from people that don't have glaucoma. And so this is what's called a Manhattan plot in this particular slide. And you can see that, again, favourite gene, CDKN2B, is right at the top of the screen, on top of lots of little blue bubbles, and you've got a whole bunch of noise in the background. What this Manhattan plot means is that for a proportion of people with glaucoma, they have an abnormality in that gene region. However, it doesn't tell us what that gene is or what that gene does. Now, CDKN2B is actually a cell cycle regulator and very common, but how is that implicated in glaucoma? We don't really know. So, you have to move to a different model, and something I've been working with for years is something called retinal explants. And so it's halfway between a test tube and an animal model. Essentially what you do is a rodent such as a rat or a mouse, they're euthanized, and the fresh tissue is dissected out, and so essentially the retina is put in a petri dish, and you can image that, as you can see in these slides here, looking at individual ganglion cells, blood vessels, nerve fibres, all that sort of stuff, and you can actually treat those explants as well to see if you can modulate what happens. Because what we know is, in this petri dish type environment, that over a period of time, the ganglion cells will just die off, as you would expect. They're deprived of their normal vascular supply, they're deprived of their normal connections to the rest of the brain, which provides nutrients. So things happen at a known rate. And it's what's called caspase-dependent apoptosis. That's just one of the common apoptosis pathways. Now, the orange bars on this graph just show ganglion cell counts, essentially in how they decline over time as the retina slowly dies. Now the blue bars basically show that when you inhibit one of the classic signs of apoptosis, it's a very fancy name drug called ZVAD, FMK. I don't really know what all that stands for either. But you can show that we can slow that a little bit. This is a very toxic drug, and you'd never think about giving it to anyone, but in an experimental model, it's very useful and sort of demonstrates how these explants work. Okay. There was a new antibody called RBPMS that actually does similar measurements, but it specifically looks at the most viable, the most alive-looking ganglion cells. So those that are a bit sick don't show up, and so you can actually see changes earlier in the retinal explant model. It doesn't take quite so long, so you can have very fast turnaround to screen potential drugs. Okay, and that's all that this particular graph shows. The details are not particularly important. All you need to know is that things happen a little bit faster when you use this particular stain. Why do you care? Because once we can identify the effect of certain drugs at such an early time, we can start looking at what happens to the gene expression at this sort of level. And here's a great little device that one of my postgrad students developed a couple of years ago called Gene Bunny, which looks at how all of these particular genes link together. So here's an example of how CDKN2B, we keep talking about this one, is linked via this molecular dominoes kind of pathway via, you can see halfway down the screen, something called CASP3, caspase-dependent apoptosis. And this is how it's all linked up. And this is how we can map out what happens where, at least on a theoretical basis. So then we can go back and look at gene expression along that pathway and see what changes when we apply a particular drug. Okay, now a slight diversion. When I was in Cambridge for a couple of years, we started playing around with just an off-the-shelf blood pressure drug called irbesartan, which is it's off patent, is available anywhere. And we showed, mostly in this particular instance, by reducing inflammation in the eye, which is essentially how these drugs work, we were able to protect the retina and confer neuroprotection. Now, there's a bit of problems why you might use this to give systemically, because a drop in blood pressure can also induce glaucoma progression. But it was an interesting way of validating the model. And on top of that, through our things like Gene Bunny, we could look at how all the genes are linked and how something like irbesartan might actually influence the molecular cascade and slow down apoptosis. So essentially, we tried this again in a mouse model because we can look at the genes a lot faster, and we can do transgenic mice as well, and we can see that irbesartan does confer some neuroprotection. You can see that on the far part of the slide with more cells, more cell counts. Okay, and Now this one shows that angiotensin blockers such as irbesartan reduce the amount of superoxide formation, which is essentially toxic metabolites made by mitochondrial dysfunction in the retina as the retina slowly dies. So the more that an eye is under stress, such as increased intraocular pressure, for example, the more superoxide tends to be produced. Irbesartan is really, really good at dampening that. And you can see that by that black screen in the bottom left part of the slide. So that's one part of the pathway, and the other part of it, you can see here that we get modification of some of the important genes in the pathway that I spoke about before. Now, which bit's the most important bit? To be honest, we don't really know. But this is basically proof of concept of how we can actually look at people with a specific genetic abnormality, finding a specific treatment for them that might be neuroprotective. This is the way forward. This is how we get to basically relatively cheap tailor-made medicine. Because a lot of the times what will modulate these complicated genes is very common off-the-shelf drugs. You just got to pick the right one. Okay, so where to next? This stuff needs a lot more development. We need to find a way to deliver it properly to the right place. We're looking at targeted sorts of drug delivery, and there's all sorts of technology about how you can do that, because probably systemic administration is just too scattergun, too messy, and too many confounders. Otherwise, it would have shown up in epidemiological studies already. But that's the way forward, that's the way of the future. However, it's the future. What sorts of stuff can we do now? Now, a lot of people might be familiar with what's called the low pressure glaucoma treatment study. It's the one that compared for people with relatively normal pressure in the eye, the efficacy of timolol versus brimonidine in terms of halting glaucoma progression. It took a long time coming out, and there was quite a bit of dropout in the brimonidine group. It is thought to be something of a bit of a flawed study, and people really can't make up their mind in this because there wasn't a lot of control to it, or people weren't very happy with it. Is brimonidine good or is timolol bad? We don't know. And so it's going to take a few more studies to do that. I mean, brimonidine, for those people that have had any experience with it, it does tend to have some allergy and tachyphylaxis effects, and patients really don't like taking it. So this hasn't really been the game changer that Allergan were kind of hoping it might be. But it does lay the groundwork for further studies. But what other stuff can we do? Okay, one of the things that one of my PhD students looked at, and unfortunately he's painfully slow at getting the papers out, but is looking at people with irritable bowel syndromes, things like Crohn's disease, irritable bowel, and other inflammatory bowel disease. Some of those younger patients, if they develop glaucoma, it's rapidly progressive. There's something to do with perhaps vitamin absorption. Vitamin D is a real possibility here, or it could be just generalized inflammation. We don't know, but there is. He's been feeding some very strange mice, some very strange yogurt in Singapore for a couple of years. So stay tuned for the findings of that, because it's very interesting. But it's a good time to talk for optometrists to remind people that this is a way that we've got to think about glaucoma patients as the whole patient. It's not just eyeballs, okay? This is a systemic disease, pretty easy to talk about, and it could flag a potential problem. Likewise, Tom Chan, one of my master's students, did a brilliant paper for American Journal of Ophthalmology that showed that if you have cardiovascular disease, your risk of rapid glaucoma progression, i.e. more than 1 to 1.5 decibels a year loss, despite optimal treatment, the odds ratio is 2.18. That's actually pretty big. So again, that's something optometrists can really ask for about the level of systemic disease. You know, have you had a heart attack? You know, have you had coronary stents? You know, that kind of stuff. It's actually really useful. Okay, but the big one where I think that everyone can play a role is, as I said at the start of the talk, people are giving up a little bit on expensive molecules to be developed. They're looking at real simple things. Now, Johnny Crouston at Sarah is looking at exercise and how that can be protective for glaucoma. The Nurses' Health study showed how dietary nitrates was very protective for glaucoma in a large epidemiological study. Yeah, the details of these slides are not terribly important, you just need to know the titles. On top of that, socioeconomic status, we know that people of lower socioeconomic groups, their general health, their diet and those sorts of things is far worse, and so is their glaucoma. irrespective of the treatment. So again, these are quite simple things that you can ask with your glaucoma patients that can tell you a lot about who is going to go bad versus who's not going to go bad at all, because it's a numbers game. There are so many people with glaucoma, half of them are not being seen, and there's not enough of a workforce of ophthalmology or optometry to see all of them. So what we really need to do is pick the ones that we need to see more closely and identify the lower risk ones that can be screened at longer intervals. Okay. The new hope this year is vitamin B3. Okay, nicotinamide. Vitamin B3 comes in two particular forms. It's on the basis of a study from the Jackson Labs, which is a famous transgenic lab in the US, and it showed that vitamin B3, it's very good at modulating those toxic mitochondrial metabolites that I was talking about with the irbesartan before. And it seemed to be quite protective in ocular hypertensive mice. Now, this has got a lot of press lately, mostly because of a study in Melbourne where they're going to look at the efficacy of it. And I get patients speaking to me at least once a week going, should I be taking lots of B3? Or I've elected not to have my surgery because I heard B3 is really good. We're not there yet. And no other major neuroprotective drug has been shown to work long term. It might be a useful adjunct, but that's the one that people are looking at this year. Okay, and so I'm just trying to emphasise to you that there's a lot of things that are not necessarily medical or surgical interventions that might be very useful, at least to provide information if you need to refer on for somebody with glaucoma, or you can talk about, and there's no reason why you can't talk about a healthy diet or vitamin supplementation as an optometrist. One of the things that is coming in, this is something in Fox News, I know in my vision, I think in the June article, June edition, there's going to be a thing on dietary supplementation and what's been shown in small-scale tests to be protective against most eye disease, including glaucoma, and it's an interesting read. So stay tuned for that. So, look, I hope that's just a little snapshot of neuroprotection and where we're at the moment and how you can potentially be involved. So thank you.
Thanks, Andrew. Stay with us for a few minutes. Feel like I'm Bruce McAvaney interviewing the Brownlows. No, that
Game of two halves, Simon.
So, no, look, that was really interesting, and given that Optometry Australia are embarking on this whole futures and looking at what 2040 is going to look like, and you know, it's really interesting to look at what treatment's going to look like, management and those sort of things. Glaucoma as a systemic disease, I think that's probably the first time a lot of people have thought of that, and I think that's really, for me personally, it's a real take-home message that we can really get bogged down thinking, oh, you know, making sure that all the eye stuff and everything that Jack mentioned was really important, but then broadening that further. For those of you at home, yes, we are conducting a near visual acuity test to make sure you can't see anything that's written on the screen this evening, so apologies for that, but the slides will be provided. Some of the things were very small. We couldn't even make them out here. So we have a couple of questions for you.
Sure.
And then we'll get on with the evening. Bad news for me, exercise and diet are two things that are important when it comes to glaucoma, because everybody's sort of, you know, anything specific with diet, anything that has come across in your research around sort of what we could recommend with patients, or in terms of anything that's come out?
Sure. Look, most of the dietary supplementation, it comes from pretty small scale studies. You're talking about sample sizes around 200 or thereabouts. But what has been shown to be very interesting and useful is, apart from the dietary nitrates, which is essentially green leafy vegetables, which is good for all sorts of eye health, is turmeric, saffron, and resveratrol, which is found in quite expensive red wine, only the good stuff, they've all been shown to be protective in small-scale studies. So how I describe it to patients is an expensive Indian meal, really. I mean, because that's basically what it is. But I mean, things like that have been shown good antioxidant properties, and it's the antioxidant properties that is what we're really looking for.
Excellent. Okay. And one of the other questions that came through is that the gene bunny that you mentioned, is it an open access?
Yes, it's available through the Westmead Institute of Medical Research website. You can access it through there. Okay.
And you mentioned sort of irritable bowel syndrome and glaucoma. Yes. A lot of these patients are on steroids for long term as well. So potentially, could that be a factor in why younger people are sort of presenting with that have these chronic conditions that are...
It may well be. I mean, we all know about steroid response, that we know that if they have an intravitreal injection of steroid, it's about 40% risk of going up. If eye drops like Maxidex, it's about 33% thereabouts. Nasal sprays, those sorts of things, about 10 to 15%. Oral steroid response, very low, 5% or under. It does happen, but it's pretty low.
So it's more the local administration.
Absolutely.
Yeah.
So, I mean, what the feeling is, the theory behind why inflammatory irritable bowel syndrome is a problem is just generalised body inflammation.
Yeah, okay.
Yeah, which is 10 points as standard. Yeah.
Sure. And just a final one, sort of more clinical. Somebody was asking, sort of in terms of definition of blindness as a practicing ophthalmologist, do you look at visual acuity or put more emphasis on the horizontal field defect? Do they go hand in hand? Sort of.
Look, you can have any sort of visual field defect with glaucoma.
Yeah.
So, I mean, we know that when you split fixation, so basically your scotoma crosses the visual axis, you go from 6.6 to 6 on 24 or thereabouts. Wow, okay, I mean, the definition of blindness is pretty much what the government says. It's worse than 6 on 60 vision or less than 10 degrees of visual field.
Right, and we know that obviously that vision can be debilitating much earlier than that.
Oh, absolutely. You know, and we're doing still, I mean, with all the new technology, they're still pretty gross tests. It's not really the subjective experience that people have.
Yeah.
Yeah.
Thank you, Doctor. I really appreciate your time this evening, and I think our audience has taken away a lot from the information that's been provided. Thank you so much.
Thank you.
Ladies and gentlemen, our final segment will be coming up in just a short break. Thank you. Welcome back, ladies and gentlemen, and thank you for joining us for our final segment on glaucoma care and the future. Everybody's favourite topic, Medicare billing, and what we do with our patients once they're out of the room. We're going to focus just for a few minutes tonight on some case studies, looking at some of the reasons why you would bill particular items and some of the hairy ones that always come up that make me one of the most unpopular people that speak at these things. So billing of patients with glaucoma. The two main items that are used, these aren't the only items, the two main items that are used are item 10914, which is a comprehensive reassessment of a patient with a progressive disorder. I've always liked to highlight that the patient doesn't need to have progression, they just need to have the disorder. So even if you don't see progression from visit to visit, if you complete and fulfil the other requirements of the item, including that it's professional attendance of more than 15 minutes, there is no installation of mydriatic required, but it obviously can still be used. If you don't do that installation at the first visit, you could always do item 918, bill item 918 for a second visit. Item 918 is for any subsequent consultation, as we all know. There is no time limitation on that item. It cannot be in relation to any contact lens item or associated with the service of item 940 or 941, everyone's favourite obstacle. But the item's always there to be used. Just looking at some of the common questions that we get asked a lot of the time. How many times a year can you bill a 914? Well, the answer really is there is no restriction on when you can bill an item, the item 914, as long as you fulfil the requirements of comprehensively reassessing the patient, you spend more than 15 minutes, the patient has a progressive disorder, then that item can be billed. It needs to be clinically justified, obviously. If you have a patient who's eligible for a 910 or a 911, do you bill the 914? At the end of the day, the answer is there is no answer. You can either bill the 911 or the 914. They both reset the clock. Some of the time, what people like to do for data and statistics gathering is that they might like to bill the 914 just to be able to track how many patients they're seeing that have a progressive disorder. They might be able to further tag that 914 in their system to say that patient has macular degeneration, that patient might have glaucoma, whatever it might be. Can you bill the 914 if you haven't seen the patient before? We get this all the time and it confuses everyone. The simple answer is yes, you can. You can bill the 914 on a patient that is brand new to your practice as long as the item descriptor is fulfilled and the patient is eligible based on the criteria. The idea behind that is if a patient comes to you with a progressive disorder, they are not restricted or disadvantaged by not being able to be comprehensively reassessed because they haven't seen you before. So these are just some of the common questions that we get around billing these items. Looking at a couple of case studies now. So case study number one, we have a 62-year-old patient that attends your practice for the first time. So you haven't seen them before. They had an eye test and they were billed a 910 2 years ago, and they do not have diabetes. They report that 12 months ago, their ophthalmologist diagnosed them with glaucoma, and they've asked you to continue their care. And they have their health record. You have access to their records to see that they, in fact, do have glaucoma. You spend more than 15 minutes and note no change to their ocular health and no visual field defect. What item would you bill? So can you bill the 910? The answer is no, because it's been less than 3 years. Can you bill item 914, given that it was the first time they attended your practice? The answer to that is yes, you can. And can you bill an item 940 even though there's no visual field defect? And the answer is yes, because you've established that they have glaucoma, presence of ocular disease. So straightforward one there. I hope there aren't any questions, but more than happy to take questions at the end. If you shoot them through, we can potentially get to them in one way. We can respond to you via email. Case study number two, a patient attended your practice last week, and based on optic nerve appearance, you suspect that they have early glaucoma. Their pressures were 24 in both eyes. They returned to your practice today for a field test, and the field test reveals that they do in fact have early glaucomatous loss. You think that while you've got them in the clinic, you might as well check to see whether their pressures are still 24, whether they're higher, whether they're lower. So you decide to also check their pressures while they come in for the field. At that second visit, can you bill item 940? Obviously the answer is yes, they have glaucoma. Can you bill item 918 because you checked their pressures? And the answer is no. And this is one of the things that we are looking at in the Medicare review. There is a clear restriction on being able to bill item 940 and 918. The item 940 is definitely only for the visual field test. The question often gets asked, well then what do I get for the IOP check? And currently the answer is, well, there's no item you can bill for it. It's certainly something that we're looking at through the Medicare review and putting to government as a means of change. Case study number three. So you attend a residential aged care facility as a health practitioner, not to live there. Your 76-year-old patient has had glaucoma for 10 years. You conduct an annual full eye examination. You also conduct a visual field test using an FDT matrix analyzer. What items would you bill at this visit? So patient has an annual eye examination. Can you bill item 911? The answer is yes. Can you bill item 940? The answer is yes. Can you bill a domiciliary loading visit while you're there, given that you've actually taken the time and gone out and took out your equipment and time out of your practice? Currently the answer is no. Once again, using items 10, 9, 31, 32 or 33 as a domiciliary loading restricts you from being able to use the visual field items 940 or 941. So you can either use one or the other. Once again, The answer to this is that it's clearly stated in the explanatory notes. It's something that with contemporary practice, modern, mobile, small visual field analyzers, it's something that needs changing. We're putting that to the government and to the advisory committee that that's something that needs to be looked at, and advocating and lobbying on your behalf for that, because we recognise that parts of the schedule are slightly out of date and needs to be reviewed. So if you're ever in any doubt as to when you should be billing Medicare items, it's really important that you go back to the 3 golden rules to see whether or not you can justify the billing of this Medicare item. Rule number 1, have you performed and recorded in your clinical notes that the service is clinically relevant? So in terms of, does the patient actually require this service? Question 2, have you met the terms of the item descriptor? So make sure you're familiar with exactly what the item descriptor's restrictions are and ensure that you've met those terms. And question 3, would you be able to justify this to a panel of your peers if you were audited, and potentially down the track to the professional services review if it was investigated further? So looking at items 10.940 and 10.941 specifically, what's on the screen is obviously not an exhaustive list, but just some examples of when you can bill these items. Any relevant clinical indication, be it sign or symptom for a visual field test, would justify the testing and Medicare billing of a perimetry item. So as I said, some of the examples are anomalies of the optic disc, for example, increased cupping or asymmetry, notching, hemorrhaging at the disc, raised CCT corrected IOPs, if confrontation indicates a visual field loss, if the patient presents with risk factors associated with glaucoma or other eye disease, for example, pseudoexfoliation or pigment dispersion syndrome, patients with unexpected visual acuity loss in one or both eyes, afferent pupil defects or other significant pupil defects, or some sort of acquired colour vision loss. Now, as I said, this list is not definitive. If you go to optometry.org.au on the members section and the Medicare page, you can go to the Medicare item use guide, and there's a 4 or 5 page summary about the use of these items. Glaucoma Australia are one of those peak body that are looking after patients with glaucoma, as well as doing a lot of work for community awareness. They're ensuring that their consumer-facing program is really important in being able to stress the importance of regular optic nerve examinations and eye examinations. They provide information and support for both patients and families, and they raise funds for glaucoma research and innovation. They certainly have a lot on their website, and we'll have a look at the next slide, to support eye and other healthcare providers to maximise patient health outcomes. And they also advocate on behalf of the glaucoma community. It's really important that when we have a patient sitting in our chairs, whether they have glaucoma or diabetes or macular degeneration, that we don't just focus, as Dr. White was talking about, not just focusing on the eyes and not just focusing on their clinical signs and symptoms, but also the more holistic global picture of what this patient might be going through, how we can help them, how we can assist them and aid them moving forward with their mobility, with their emotional support, with any sort of other support that they require with their lifestyle, given that they're living with this disease for a number of years. So please consider that. If we have a look, I've just taken up the screen. There we go. Looking at the actual Glaucoma Australia website, there's a lot there around living with glaucoma. There are brochures and books and videos. There's ability for the patients to find other professionals to help them. Really, there's not much more you need to do other than guide them and direct them to the website and maybe give them a brochure. And it's really going to go a long way to help them. We found a lot of patients, through our Good Vision for Life campaign, we found a lot of patients have come and looked for this sort of information. So it's really important that we consider more holistically a global approach. Ladies and gentlemen, that concludes our webcast for the evening, Glaucoma Care in the Future. We'd like to thank you all for attending. Before you switch off, one of the things that I do need to flag is that an evaluation form and your multiple choice questions for the evening will be sent through an email to you in a link. Please complete the evaluation, because the evaluation is of utmost importance for us to understand what it is that you want to hear, why it is you're switching on, and what we can provide for you. So it's really important that you're able to give us that feedback so we can provide you with more and more of these opportunities. We'd like to thank Novartis, our primary sponsor this evening, for being able to support the evening. And we look forward to seeing you again at our next webcast. If there are any other questions, our phone number is at the bottom there, and you can log on to optometry.org.au for more information. Thank you and have a good evening.